we get started, and then we'll have other people join. So good evening all to this weekly huddle. My name is Anup Agrawal. I am an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host for the huddle, Praneeth Palamari, whose voice you were hearing just a few seconds ago. The huddle is an unscripted audience-level interaction which addresses common clinical scenarios, research findings, news lifestyle, among others. We aim to keep the discussion patient and practice-oriented. So what we do is we typically pick up a topic and or a clinical case and restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussions to a more organized platform like this one and share our ideas collectively. While science and guidelines are welcome in this discussion, the huddle intends to help a physician translate established knowledge to clinical practice, taking local factors and practice patterns into account. We host this session every Wednesday at 7:30, like today. And this is our 32nd session. With every week, we have been doing it for just over 7 months now. Today's topic for discussion is adult vaccination, something that we do see quite frequently. So the way the huddle is designed is I start with a clinical case and we try to restrict our discussion around that clinical case itself. I ask my colleague Praneeth for his opinion first, and then we open it for discussion to the audience. Anybody who is participating, please feel free to unmute yourself and share your thoughts. As a courtesy, you let the other person finish and then you can speak, or you can simply raise your hand and wait for your turn. So having said that, this is my case, Praneeth, and then we'll get your opinion and then we will go from there. So this is a 62-year-old female. She has a history of diabetes for about 10, 12 years now, hypertension around the same time. She was diagnosed with inferior wall MI around 6 years ago. At that time, she was 56 years of age, and she had a primary PTCA done to RCA. She has a good LV function. Last month, she was admitted at Care for COVID pneumonia. And at that time, her symptoms were fever, sore throat, and some early oxygen desaturation. Her oxygen were about 91, 92% at room air. She was admitted in room and was treated for 5 days with supportive therapy, and following which she was discharged. Her COVID testing 2 weeks later was negative, that was RT-PCR. She had been at home for the past 1 month, and for the past 2 weeks, she had been pretty much asymptomatic at home without any fever, cough, or anything. So she's about 1 month since her last RT-PCR positivity with an interim RT-PCR negative. So she seems to be free of disease now. She's otherwise okay, walking and doing everything all right. She came for a follow-up, and I saw her about 4 days ago, and she's 62, otherwise okay. She's not reporting any angina, not reporting any other symptoms. She's on statin, clopidogrel. She was put on Eliquis post-COVID for about a month, which is supposed to be stopped now. She's on ARB and other routine diabetic medications. She does not remember when was the last time she got vaccinated, certainly not in the last 10, 12 years or so. And as you know, in our clinic, we have got this alert system where every patient who comes to our OPD, we get a OPD stamp saying whether this patient got vaccinated for the 2 vaccines that we're talking about, influenza and pneumonia as the most common vaccination for adults in our space that we talk about. So the patient looked at that alert system and asked me whether she should get vaccinated for influenza and or pneumonia, understanding that she had never been vaccinated before. And her follow-up question was, will she be a candidate for COVID vaccine in case if that comes up next month? And if we go by the news, it's very much possible that in early January, we may have a COVID vaccine marketed in India. So Praneeth, the question to you will be, now it is 15th December or 16th December. She is about 1 month post-COVID. Would you offer her influenza and or pneumonia vaccine now first? And second, how does it change for you to offer COVID next month, knowing that she already got COVID pneumonia before and that she got a recent vaccination if you end up giving her vaccination right now? So just walk us through what your thought process is, and then we'll ask others to share their thought as well. Praneeth.
Yeah. So 62 hypertensive diabetic with a cardiac disease, so-called coronary artery disease, but a good LV function, puts her slightly at a risk of having the intercurrent seasonal flus and infections. So ideally speaking, if no risk factor 65, I believe is a recommendation to give. And those patients who have heart disease, coronary artery disease, heart failure, kidney disease, or CLD, etc., they are supposed to receive vaccination. My thought process. So this patient, because she has established coronary artery disease, I would recommend her to receive both the vaccines, the influenza vaccine and the pneumococcal vaccine. Regarding the follow-up question of COVID vaccination, I believe the once you have infection, the antibodies are there, and the severe is the infection, the more is the antibody titer. Someone who had severe pneumonia and requiring maybe oxygenation or maybe NIV or a ventilatory support, their antibody titers are high compared to those who are asymptomatic or who had a mild disease. And now that this patient will definitely have antibodies, and as per my knowledge goes, the antibodies do last for something like 3 to 4 months. So immediately, whether first is about whether she will be a candidate to receive vaccine, because I believe there are now regulations that only those who are not infected and not in the extremes of age, like children, infants, and elderly, they are currently not eligible. But say if it is available all throughout, I would still advise her to take the vaccine, because those antibodies which are acquired due to infection, they are said to be lasting for only few months. So I would still recommend her to take COVID vaccine. This is my take on it.
So Praneeth, the question that is going to come is this patient who is just 1 month post COVID recovery, and be it COVID or be it any other acute illness, typically how long do you wait before you offer them the routine influenza or pneumococcal vaccine?
4 to 6 weeks, Anup.
And do you think it is going to be any different for COVID, although the information is quite limited? What is your thought?
I would again say the same thing. I would wait for 4 to 6 weeks, and in the next 4 to 6 weeks, if the patient is fine, I would try to do what I'm doing for regular
Right.
patient.
So currently she's 4 weeks out and she's doing fine. So
Yeah.
from your side, you would be okay giving her both the vaccines, right?
Yes. Yes.
Okay. Okay. All right. Perfect. Let us ask my other colleagues who are here in the audience and see what their thought process is. Let me see. Dr. Chandramukhi is here with us. Dr. Chandramukhi. Yeah,
Hello.
Chandramukhi ma'am, sorry, I was muted for a second. I have two questions for you, ma'am. Question one is about this particular case in terms of whether you would be okay giving this patient vaccine right now or not. And question number two, as a general, and this is not particularly for you, but what is your impression of patients coming to cardiology OPD who qualify for adult vaccination, particularly influenza and pneumococcal? In your impression, what percentage of the patients end up receiving vaccination? So first, the clinical case, and secondly, what is your impression of the overall penetrance of vaccination? Chandramukhi ma'am.
Good evening, all. Regarding the first question about this patient, already she has suffered COVID infection, but as it is already said that the antibodies will not last for a longer duration. They may last for about 4 to 5 months. So she should receive the COVID vaccine. But the time when she should receive, I'm not very sure. Should we check the antibodies level before we advocate the COVID vaccine? That is my query. And regarding the second question, like influenza and pneumococcal vaccine in cardiology OPD, yes, many of the patients which we see have risk factors and they are high risk for these infections, and they should receive the pneumococcal and influenza flu vaccine. But as per my observation, few patients are receiving this. All the majority of the patients who should receive are not receiving these vaccines. Maybe I don't know what is the cause, but few patients are receiving these vaccinations.
And ma'am, for this particular patient, 4 weeks post-recovery, would you offer this patient influenza and pneumococcal vaccine right now? Or would you wait for longer?
I feel I should wait for the pneumococcal and flu vaccine in this case.
For how long?
Exact duration I'm not aware, but I think once she has she has suffered the COVID illness, giving these vaccinations for about 6 months, she should receive this. I'm not sure. I'm not sure about the duration.
Thank you so much, ma'am. I think this is going to be the new era or a new understanding for all of us in terms of most of these patients who should have got these vaccinations, namely influenza and pneumococcal, they have not. In fact, those patients who were routinely getting vaccinations, even they did not get vaccination in the year 2020 because of various concerns, including not getting proper care out of COVID scare, truly speaking. And now there is going to be a little bit of catch up in terms of whom to vaccinate, whom not to vaccinate, particularly how is active COVID infection going to interfere with the vaccine response, or those patients who are COVID survivors, whether their antibodies are going to interact with the vaccination that we're going to give. And truly speaking, I don't have a clear answer. I don't know if a lot of us have clear answer. The general advocacy is to vaccinate everybody, but we certainly need to have a little bit of thought process on how to go about it. Let me ask somebody else for their thought. Dr. Shankar is with us. Dr. Shankar is a general physician. He, I'm sure, gets involved with a lot more vaccinations than typical cardiologists do. Dr. Shankar, we are talking about a patient who has got diabetes, hypertension, coronary artery disease, 62 female. She had COVID pneumonia a month ago, now completely recovered. The question are twofold. Number one, should we be offering flu and pneumococcal vaccine at this time, or should we wait for a little bit longer? That is one, is there a thought or a science behind it? And number two, will she be a candidate for COVID vaccine when the vaccine does come? And how is the current vaccination going to interfere with her future vaccination? Dr. Shankar, your thoughts.
Good evening. As we have discussed just now, this patient is quite suitable for vaccination, adult vaccination, adult immunization, with both influenza and as pneumococcal vaccine. She is a suitable candidate for both the vaccines. And within a short period, we are also getting the COVID vaccine also. But I don't know whether this COVID vaccine will interfere with the immune process with the influenza and pneumococcal vaccines, yet to know. But in my view, this patient has recovered from the COVID-19. She needs the newer vaccine, either Oxford, AstraZeneca, or Pfizer, Moderna, or Covaxin, Bharat Biotech, or Sputnik, any vaccine, because there are quite a number of reports are there. After the COVID-19 infection, there are three categories of patients are seen with the immunity process. Few patients are, they have not developed any immunity at all. Very few antibodies are neutralizing antibodies were seen. And the second category, only partial immunity was partial immunity developed. And in few patients, only the complete immunity developed. And this is the very, only he recovered only past 1 month. He definitely needs a COVID vaccine, whatever available in the market tomorrow, either mRNA or particle or spike protein, any vaccine, he needs this vaccine. I am worried about when we give 3 vaccines within a short span of time, the immune process may be hampered with the one another. That is my, but influenza and pneumococcal can be given together. There is no problem. Quite a number of reports are there. There is no, but only thing is amongst the pneumococcal, if PPSV 23 or PCV 13 are given less than 8 weeks, but because of some guidelines they say that more than 1 year we should wait. That will come to later for the discussion sake. But influenza and pneumococcal vaccines can be given simultaneously. But I am worried about, along with the influenza and pneumococcal vaccine, if you give a COVID vaccine, what about the immunity process? Simultaneously, the three vaccine process will be going on, the B-cell, T-cell immunity. So there may be interference, I am suspecting. So what will be the guidelines, correct guidelines and the standard guidelines we are waiting for? Thank you.
Dr. Shankar, before I let you go, I have a few follow-up questions for you. Number one, so you answered most of it. One question you did not answer is 1 month post-COVID, are you okay giving vaccination now, or would you like to wait and then give?
We can give influenza and pneumococcal vaccine. There is no,
even right now.
Even right now.
Second question is, there are 2 kinds of influenza vaccine available. Sorry, I'm asking all this question to you.
Okay,
because
okay,
you
sir.
are the
Okay, I am
most senior physician
as far
here.
as my knowledge goes,
Sure.
I will answer.
Sir, there are 2 kinds of influenza vaccine floating around in the market right now. Which one do you prefer and why?
There are 2 vaccines, trivalent vaccine and the quadrivalent vaccines are there. Then LAIV also there, but most of the times we don't use. The quadrivalent vaccine I prefer, if it is available.
And why?
Why means it covers the most of the strains, influenza A, influenza B, and even in the influenza A also the subtypes also being covered with this quadrivalent vaccine. And whereas the trivalent vaccine covers only A and B, but more than that, benefit will be there with the quadrivalent vaccine.
Sure. And then the second question is, even pneumococcal vaccine, there are 2 types floating around. Which one do you prefer? And for this particular patient, which one would you offer?
I suppose the patient was, and the patient, did she receive pneumococcal vaccine earlier?
No, so she is a 62-year-old female, never had any adult vaccination before.
Then we have to give PCV 13.
Okay.
PCV 13, and the CDC and the ASCP guidelines are the different. But in Indian guidelines are a little different regarding the adult vaccination given by the Association of Physicians of India recommendation. PCV 13 will be given first, and after at least after 8 weeks, we can give PPSV 23.
And sir, could you just in 2 minutes give us a little bit of rundown, because a lot of us may not know the difference between 13 and 23, and other than, I can guess 13 has got 13 antigens, 23 has got 23 antigens, but other than that, if you could just give us a brief rundown, the difference between the two, and when do you give a booster injection?
PPSV 23, as you said, it is a 23 valent. It is a polysaccharide vaccine, and the immunity will be B cell dependent. It is B cell immunity will be there with that PPSV 23, and it is inexpensive. It is not. It's cost effective. It is very compared to PCV 13. It is cheaper, and PCV 13. It is the conjugate vaccine. 13 valency. Earlier it was a PCV 7 was there, but now PCV 13 is also available since 2012 or 13. It is being marketed globally. So PCV 13 gives this T cell dependent immunity. Though it is expensive, this gives a T cell immunity. That's why this PCV 13 is preferred more than 65 years of age. And though she is around 62, even 19 to 64 years of age also, we can give PCV 13, followed by after 8 weeks, we can give PPSV 23. Suppose if the PCV 13 is not available, or if there is any shortage, then we can give PPSV 23, but we have to repeat PPSV 23 again after 5 years. Whereas the PCV 13 can be a single shot. Especially between 19 to 64 years.
And sir, what is the youngest age where you offer them pneumococcal vaccine, or would you recommend in every patient who has got cardiac disease or a cardiac risk factor?
It can be started even from after 2 years of age.
Okay. Okay. And is it always 13 first followed by 23? If they are available?
If they are available, the 13 is first. International guidelines are there. That is Advisory Committee on Immunization Practices, or CDC 2018 or 2019 of AICP guidelines. They clearly mention that PCV 13 should be given first. For if 19 to 24, 19 to 64 years of age, only single shot. But if the patient is more than 65 years of age, then PCV 13 should be followed by PPSV 23 with a gap of 8 weeks.
Perfect. Thank you so much, sir, for that sharing your knowledge base to the audience. The pneumococcal 13 vaccine, commonly for us to know, the brand name available is Prevenar. And Shankar sir, please correct me if I'm wrong.
Yes, correct.
And,
Prevenar 13, correct.
And for 23, the brand name available is Pneumovax, right?
Correct.
So we always give Prevenar first, followed by Pneumovax second, particularly in our cardiac patients, where we do want to give them 2 doses. One was 13 and the second one of 23. So let us move on to our discussion. I will invite other audience members' thought, and I will be asking very specific questions because the clinical case that we are discussing, we have got a little bit of consensus that most of us, we will vaccinate this patient at 4 weeks post-recovery with both influenza and pneumococcal, and this time we will be giving quadriflu, which is 4 antigen, 4 strain influenza vaccine, as well as Prevenar 13, which is PCV 13. I'm going to ask a few of my colleagues, and I'll pick their names. Let's say Dr. Prashant, if you could unmute yourself. Dr. Prashant is a cardiologist. He used to be with us at CARE. Dr. Prashant, I have got two questions. Number one, whatever you heard about this clinical case, if you have a difference in opinion, and second, how frequently you see in your practice patients with cardiac issues getting offered vaccinations, adult vaccinations, what kind of challenges you face in your clinical practice? Dr. Prashant.
Yeah. Hello, sir. Good evening. I agree with most of the things which were discussed, sir, of the influenza and the pneumococcal vaccine, giving quadrivalent influenza vaccines. And this patient can be immunized now. I think what I heard is at least after she got recovered, if it is more than 2 months, then I'll be okay with immunizing her with a quadrivalent influenza vaccine and then Prevnar pneumococcal vaccine. And in my practice here, there is too much ignorance, not of patients, but of doctors. Nobody recommends patients, nobody advises the patient. So there is no issue of patient knowing that they have to be vaccinated. We of course advise patients, but they are very ignorant also that there is no vaccination to be taken for adults. So this is what the situation is in my region. But I advise for elderly people who had a CAD in my OPD to get vaccinated. Most of the times they refuse it. The people who are educated, they go for this pneumococcal and influenza vaccines every year. So it is not very common in my OPD, but the educated people, they still follow the practices.
Thank you, Dr. Prashant. One more question that came up in the audience is that if PCV13 is skipped and a patient directly gets Pneumovax 23, then what should be done? And to the best of my knowledge, and Dr. Shankar or anybody can correct me, if Pneumovax is given, you can still give PCV13 later on. The whole idea is that PCV13 is more antigenic, so it mounts a much stronger response as compared to the Pneumovax. So if somebody got a Pneumovax, they can still get a PCV13 after a time duration typically considered 1 year or more, followed by a booster dose of Pneumovax. That is my understanding, and that booster dose has to be at the age more than 65. So that's my understanding. It's a little bit complicated. If anybody has got any suggestions on that, they can unmute themselves. In the meantime, I'll keep continuing my discussion. Shankar sir, you have anything to add about it?
You are 100% correct, because when PCV13 is not available, or earlier also it was not available in India, so PPSV was given. So when PCV13 was made available, that was given after 1 year. See, more than 65 years of age individuals, we give PCV13 followed by PPSV 23 after 8 weeks of gap. For example, as you told, patient has already taken Pneumovax, PPSV 23. So then we have to wait for 1 year to give this PCV13 vaccine, the Prevnar 13, because the PPSV is a B cell dependent vaccine, produces a B cell immunity that will be hampered if you give early the PCV13, which is the T cell dependent. So T cell immunity, immune process will hamper the B cell immunity. So there is no point in giving two vaccines with 8 weeks apart, especially with the PPSV followed by PCV13. But here we have to wait for 1 year. This is quite important. When we give Pneumovax first, we have to wait for 1 year to give Prevnar 13. This is
Perfect.
clear.
Perfect. Thank you so much, Pranit. I hope that answered your question. If not, you can please write a follow-up query on the chat box, and we'll try to address that as well. I'll keep continuing my discussion. I will ask Dr. Prithvi. Dr. Prithvi is a cardiologist. I will ask Dr. Prithvi about his opinion on the clinical case that we are discussing, if anything that you disagree with. And I have a particular question for you. What can we do if you believe that the vaccination penetrance in the adult population, the kind of patients me and you see in our OPD, if you believe that the vaccination penetrance is less, what have you done in your clinic to improve that penetrance, or what can you suggest this audience to improve vaccination penetrance within our patients? Dr. Prithvi, if you could share your experiences with us. Please unmute yourself. Dr. Prithvi, you'll have to unmute yourself. We cannot hear you. Okay, looks like there is some problem getting Dr. Prithvi online. Dr. Praveen, if you could follow up the same question that I asked Dr. Prithvi in terms of any difference or anything you wanted to add to the current discussion, and how we can improve vaccination penetrance in our particular OPDs. Dr. Praveen, if you could unmute yourself, please.
Good evening, everybody. I just agree all the points with Dr. Anup, what he has said, that the prevalence of adult vaccination, especially in cardiac and other patients, are very low in the general practice. Here, practice in a three-tier town. Here. First, a few years before, initially when I was here also. Then we could take after a few years, we got we start stepping. Something I just want to add is I just want to know the opinion of other persons. Like, would you prefer giving vaccine for all the cardiac disease patients, or would you see the patients who are having some heart failure? Would you differentiate, and would you prefer giving vaccine to, especially to those patients with a reduced ejection fraction and COPD and diabetes? One point regarding that. And as you have said, that patients are very, except them, they don't follow vaccination.
Thank you, Dr. Praveen. Let me get back to Dr. Chandramukhi. Dr. Chandramukhi, I don't know if you were able to hear what Dr. Praveen said. His voice was breaking a little bit. His question was, to our cardiac patient, should we offer vaccination to every patient, or should we be selective and only offer vaccination to those patients who have heart failure or COPD or something of that sort? And then my question to you is, how can we improve vaccination penetrance in our own OPD? What have you done that worked for your OPD? If you could share your tips and tricks.
If the patient is more than 65 years, then we can vaccinate these patients. And if the patient is less than 65 years, then we need to have to consider the risk factors like coronary artery disease, heart failure, and LV function. So if they have risk factors, and other comorbidities like COPD, then we tell them to go for vaccination. So I feel how we can improve the vaccination status in our OPD is like we can keep some placards, or we can keep some flyers which tell what benefits the patient will have if they get vaccinated. And when the patients come to us, we should tell them about the vaccination, because many of these patients, they will not know about the vaccines and what will be the benefits of vaccination. Thank you.
Thank you so much, ma'am. Praneeth, you want to weigh in into this? The discussion going on is, should we be selective in offering vaccination to patients? And second, how can we improve vaccination penetrance to our patients?
I would say for most of the patients, I would give mostly ejection fraction a weightage. If the ejection fraction is something like less than 40%, I would definitely consider giving vaccination, even though they are younger in age group. And probably diabetes is something again which favors me to give them vaccination. And irrespective of their disease status, someone who is more than 65 again uh, tilt towards giving them vaccination. That is my take on it. Regarding improvement in compliance or increasing the vaccination program, already I think there are these stamps, OPD stamps, which are kept about vaccination. Someone who is plus 65, the the stamp of vaccination should probably come as a reminder to the physician, not only a cardiologist, but any person who is going to any physician, probably a stamp just as a reminder, be it physician or even a surgeon. That is one. And probably having our own program of ejection fraction. Someone who has an gets an echo done in a echo room, gets notified as a ejection fraction less than 40%, again probably gets a stamp or a sticker as a reminder about vaccination. Probably these are two things which I could think of to increase the compliance of vaccination.
Thank you, Praneeth. Anybody has any other thoughts before I continue with the discussion? So I'll give you my thoughts on the vaccination program. So for me, influenza vaccine is for everyone, anybody who is adult who walks into my OPD. If I remember, and if the patient is willing, influenza vaccine is for anybody age more than 18 who hits my OPD gets offered an influenza vaccine. In fact, if I see a patient 50-year-old who comes in with a 25-year-old kid, I offer vaccine to both the 50-year-old as well as to the 25-year-old. And at the same time, I tell them, go and bring your other family members and get influenza vaccine. So for me, influenza vaccine is for everybody who is an adult, who is not immunocompromised, or who does not have any other major systemic illness. That is for influenza. For pneumococcal, things are a little bit more complicated because you have to weigh the risks and the benefit. The risks mostly relates to the issue of financial constraint for a public vaccination program. So remember that the number age 65 is for the Caucasian, for the Western population. They have expected life of about 78 years. So when you start vaccinating at the age of 65, they have about 15 more years as compared to in India, where the life expectancy is close to 70 years. So while I do acknowledge the age 65 listed by the Western guidelines, I tend to err on the side of age 60 or so. So to me, any patient age more than 60 without any risk factors gets offered influenza vaccine, pneumococcal vaccine. And any person age more than 40 plus who has got risk factors for cardiovascular disease like bad diabetes or COPD, like for instance, any chronic lung pathology, or who have got hypertensive heart disease, who are at risk for heart failure, or what we typically call it as a stage A heart failure. All these patients age more than 40, I do offer them pneumococcal vaccine, and I offer them Prevenar followed by Pneumovax to begin with. So after hearing the audience here, I think I am a little bit more aggressive in terms of offering them vaccination. But believe me or not, the biggest problem I personally don't think is education. I believe the biggest problem is the constant reminder. Patients typically they enter our room with some kind of medical complaint that they want to discuss with, and within the time span, that interactive time is eaten up mostly in troubleshooting what the common complaint is rather than talking about their vaccination. So a little bit of inertia is there on the doctor side as well, where it doesn't get reminded. So while education is important, in my opinion, a constant reminder is very important, both for the patient as well as for the doctors. So stamps or displays or those kind of things are very important. I remember in my training where we had electronic medical record, no matter why you have opened a patient's medical record, if you close it, the moment you try to close it, EMR would detect that this patient is not vaccinated for the age appropriateness, and it would alert us to say, do you want to vaccinate your patient today? You can clearly say no and then close it. The system is not going to force you to say yes, but it used to act as a reminder that these patients, they need to be vaccinated, because often in this acute medicine practice, we tend to forget the vaccination thing. There is a question in the audience about live attenuated vaccine, live attenuated influenza vaccine contraindicated for elderly more than 65. So I don't know that answer. I don't know if we are giving live attenuated influenza vaccine. If anybody has got any thought, they can please share with us. I don't know about live attenuated. The second question is, should I as a healthcare provider take influenza vaccine? I have no risk factors. And again, I grew up in a training program where every healthcare worker was expected to get influenza vaccine. In fact, it was a breach in professionalism. If you are seeing patients and not getting influenza vaccine, it was a breach in professionalism. A lot of hospitals will put you out of the role if you are not properly vaccinated for that particular year. I know in India it is not practiced that strongly, but since I came here, I have been practicing it diligently. Me, my wife, my kid, each one of us, we get annual vaccination. And as I said, forget healthcare providers. I even offer influenza vaccine to the son of my cardiac patient. So in my opinion, every single adult who does not have a contraindication for vaccination should get influenza vaccine. In India, we do have to be mindful of the cost, though. If a patient cannot afford his diabetes medication, then probably vaccination is not worth spending that extra money. So that's altogether a different subset of how socially we can help them. But in my opinion, everybody should get influenza vaccine. And if you're a healthcare provider, you absolutely should get influenza vaccine. If anybody has got any thoughts to add or a counterpoint, please unmute yourself. I think this is a discussion which is worth having. Who should get influenza vaccine, and should healthcare workers should definitely get influenza vaccine or not? And if somebody knows the answer to the live attenuated influenza vaccine. Okay, one of the questions that came is, are the strains suitable for Indian population? To my understanding, yes. The influenza vaccines, they are upgraded every year, and they do claim, at least they claim, that they have put on the local strain for that particular year and that particular region. So I believe that the vaccines, the influenza vaccines, are upgraded every year to include the local strains. Remember, pneumococcal and other vaccinations, they don't need to upgrade their strain, but influenza do. And I think they do. Anybody else has got any other thoughts about these vaccination program? I have a few more questions which I'm going to go forward. If nobody has anything to add, I'm going to give a few seconds for people to gather their thoughts in case if they want anything to add. Yes, Praneeth, go ahead.
Yeah, the two common questions which are asked in the OPD practice when we discuss about vaccination, which I already posted, is one, why do I need to get vaccinated? How does it going to help me? And equally, because they are a bit expensive, the same thing is about how is it cost effective? How do we get convinced our patient, or equally, how do we advise this patient when we look into cost everywhere in our practice?
So I think that the confusion also needs to be cleared in terms of what are the intentions of vaccination. So when we talk about influenza vaccine, then influenza vaccine for most part works. And works, I mean, the 4 strain for which you are vaccinating, it takes about 4 weeks for the antibodies to develop. And after 4 weeks, for the next 7-8 months, you should not get, your body should be immune to handle those 4 strains. And those 4 strains are what scientists assume beforehand that they are going to be, it's like a calculated guess. they believe that these 4 strains are going to be the common strain going forward in the next 1 year or so. So the so-called 2021 strain for a 2020 vaccine, that you pick up those strains which come up early in the community and then you extrapolate that data and put those. So a patient who is getting the influenza vaccine, we should be able to tell them that in the next year or so, you should be protected against this 4 common strain of influenza. What you wouldn't be protected against are other uncommon strain of influenza and other viral infections that may come across. Now, why do people need to be careful about influenza? It's a mild upper respiratory tract infection to begin with, and the answer are twofold. One, the same URI viral infection in a risk population, like your typical cardiac patient, can decompensate them and cause a lot of damage. As far as the young population is concerned, they can act as a carrier and effectively transmit the infection to their near and dear ones, like a 25-year-old kid getting influenza infection, giving it to his or her father or mother, and effectively now the parents getting in trouble. So at-risk population should get vaccinated to protect themselves against these antigens, and the low-risk people should get vaccinated to protect their friends and families around them so that they don't become the vector for transmission. So that is the target that we're trying to achieve with influenza. As well as with pneumococcal vaccine is concerned, there we are only targeting one particular bacteria which causes the most severe form of, typically most severe form of pneumonia. And patients need to understand that a pneumococcal vaccine does not prevent you from getting streptococcal pneumonia. It prepares your body so that you are able to fight that streptococcal pneumonia much better, and your chances of landing into severe pneumonia or decompensated pneumonia due to streptococcus pneumoniae infection, that goes down. So your risk of pneumonia goes down a little bit, but your risk of severe pneumonia because of streptococcal pneumonia, that goes down, and that's worth the price that you are paying for the vaccination. Remember, pneumococcal vaccine is only 1 or 2 doses that you're going to take for the rest of your life. While it gives you kind of protection for only one bacteria, it's a very dangerous pneumonia with very florid course, particularly in at-risk patient. Pneumococcal vaccine does not have the so-called herd effect. That is why we don't offer it to all the random 25-year-olds, because for them it really doesn't matter, and they're not going to transmit this bacteria to others. But for influenza, that matters. So I think for us to understand what we are trying to achieve with the vaccination and to transmit the same to the patient so that patients understand what they are getting into, so that they don't have this false belief that they get a pneumococcal vaccine and now they can never get pneumonia again. Those expectations and knowledge has to be well set. If we vaccinate, let's say 20 people and prevent one major pneumonia episode, that price is worth paying for. Even if you don't, let's say, save lives, although you do save life, but even for the sake of discussion, let's say even if you don't save life, if you prevent one admission, one decompensated admission in those at-risk individuals, that's a price worth paying. These vaccines, they cost somewhere around 1,500 to 2,000 rupees, and they are pretty safe, and they certainly are good money to be invested, if I may. I hope that kind of clears a little bit, and I'm just going to look at the other questions. What is the best time for vaccination? I don't particularly know if there is a best time for vaccination. Vaccination can be given at any time. If you're talking about day and night, that is the same. If you're talking about weeks or months, for pneumococcal, again, it doesn't matter. For influenza, if you are at the time of August, September or so for a year, then you wait for the next strain to come, and then only typically a next strain is available by end September, early October. So if you are in that August, September range, then you wait for the new strain to appear. But if you are in the early phase of the year, then you take that strain, and then later on the year, you can take the newer strain available as well. So for the month, that is the best time. Day and night, it really doesn't matter. For pneumococcal, nothing matters. Can both the vaccine be taken at the same time? Yes, both the vaccine can be taken at the same time. I don't see any problem with that. So if nobody has any other thoughts, I'm going to get back to Dr. Shankar. I have one or two more questions. Shamim, you raised your hand. Is there something you want to add or question? Shamim, you want to unmute yourself and ask your question or share your thoughts? Okay, Dr. Shankar, I'm going to get back to you for very few specific questions. When we talk about adult vaccination, for some reason we restrict ourselves to influenza and pneumococcal. I'm going to ask you very specific questions for the kind of adult subset that we deal with, typically patients in their 40s and 50s with either established cardiovascular disease or risk for cardiovascular disease. What is the role of typhoid vaccine in our adult subset? If you could answer that in one or two sentences.
That is, typhoid vaccine is also quite useful.
Okay. And do you think we should consider it in our patient subset?
Yeah, definitely. It is included in the adult vaccination. This typhoid vaccine, hepatitis B, even hepatitis A,
Right.
even many other vaccines are there in the adult immunization.
Right.
But we are concentrating mostly on influenza and pneumococcal vaccination.
Pneumococcal, right.
But
right.
in spite of that, also there are so many barriers, even from physicians, for the patients, relatives. It is very difficult. Actually, it is not as it is easy to tell.
Right, right. Sir, do you, when you think of vaccinating an adult with typhoid vaccine, do you take into account if they had typhoid in the past or not? And if they did have typhoid, do they still get a vaccination?
Even after the attack of typhoid fever, also we administer typhoid vaccine.
Okay. And I believe the vaccine is called Typhoral or something, right?
Typhoid. There are two varieties are there. Some intramuscular is there, and oral. Typhoid oral is also there.
I see. I see. And one question that audience asked, I don't know if you know the answer or not. The live attenuated influenza vaccine, is it available? Do you know anything about it? Is it contraindicated in elderly?
That I want to know from the audience. Okay. If any vaccinologist is there, he will answer that question, because the live attenuated influenza vaccine, it should be given intranasally. There is no need of parenteral. As you said, it is contraindicated even in immunocompromised patients and in adults, in elderly patients. So whether it is available or not, I don't know. But the only thing is that the popular one is the quadrivalent vaccine, which is quite available in the market. If it is not available, trivalent can be given in that instead.
So
if it is not.
In my training program in the States, we used to get, as I was saying, all of our healthcare workers, we used to get vaccinated with influenza, and we were getting live attenuated vaccine. But I have never studied about it, whether you need to select candidacy or not. But because it was easy to administer, a nurse can literally administer more than 100 people over a few hours. So intranasal live attenuated was the way to go in our hospital setup, but I don't know the details. Sir, second question for you for adult vaccination, how do you deal with tetanus and Tdap or Tdp, whatever that vaccination is? This is again something we don't talk about in our adult vaccination that frequently. If you could share your thoughts.
Yeah, this Tdap, actually, it is advised in adults. Tetanus, diphtheria, and acellular pertussis. This is given to the adults, and it is followed by booster dose with only tetanus and diphtheria after 10 years. Every 10 years, we have to give a booster with tetanus and the diphtheria, only TD vaccine.
And is it available? Is the Tdap vaccine available with us, sir?
Tdap is available. That is no doubt. Tdap
That is with the brand name of?
I don't know, but this
Okay.
this
But it is
Tdap is
available.
available.
We can write a Tdap and it will be a acellular pertussis, right?
Yeah, acellular pertussis.
That will be available. And the third question is, again, I'm recollecting my training days in my medicine. In US, there was this big deal of giving shingles vaccine to elderly population age more than 65. What do we do in India, sir?
This is also available in India as a brand name is Shingrix. Just like hepatitis B is Engerix, this herpes zoster vaccine is available as a Shingrix. But in India, we give this recombinant zoster virus vaccine in 2 doses. Earlier, we used to give more than 60 years of age individuals as a single shot. But this Shingrix, this recombinant zoster virus vaccine, we give 2 doses with more than 4 weeks apart. Indication is more than 50 years of age.
And that zoster you are talking about, the Zostavax vaccine that comes, right?
That vaccine.
So, sir,
but this is a recombinant vaccine.
Yeah.
What we are giving this Shingrix.
Right, because I remember that Zostavax vaccine back in the day, we used to talk that how Shingrix is much better than Zostavax. Is Shingrix available? Can we use it freely in India?
Yeah, it is available, freely available in India. Okay. But only thing is we should give 2 doses.
2 doses.
With,
okay.
With 4 weeks apart.
And last question to you, that as a cardiologist, seeing these kind of patients like the index case that I talked about, a 62-year-old female with coronary artery disease, diabetes, hypertension who comes to our OPD, should we be thinking of all these vaccines in terms of typhoid, Tdap, shingles on the top of influenza, pneumonia, or you think it is too much for these patients to assimilate, and how to work through it? What is your thought on this?
See, influenza and pneumococcal vaccine can be given, as you said, at the same time. But these vaccines should be given a little distance apart, because all the vaccines cannot be given at the same time. But especially of all the adult vaccinations, so many are available in the market, like human papillomavirus, hepatitis A virus, so many things, so many are there. But selectively, we concentrate on only 4 vaccines as a physician. We recommend, but they are quite useful. These only 4. These are Tdap, herpes zoster vaccine, and influenza and pneumococcal. And if they are not being given this hepatitis B vaccine, that is worth giving at least 3 doses of Engerix B. But most of the, I think, most of the people, they have taken a hepatitis B vaccine because there was a very good heavy campaign was there for giving this hepatitis B vaccine, when even Shanwalk, which is our indigenous vaccine, it is available at a cheaper rate. So Shantabiotic. So most of the people have been vaccinated with hepatitis B. If they are not vaccinated, we give hepatitis B also. But I stress on these only 4 vaccines amongst the adult vaccination or immunization: influenza, pneumococcal, Tdap, and herpes zoster. If anything, patient, we can give any number, but patient cannot tolerate. And even if you give more vaccinations, one of the etiological factors for the amyloidosis is also frequent vaccinations and more vaccinations.
Perfect. Thank you so much, sir, for your insight. And as a homework, if I may ask the attendees for this session, that once the session is over, if you could just introspect and see what all vaccination as per ACIP program you should be vaccinated for, and whether you are up to date with your own vaccination. And with the same exercise, continuing it to your OPD when you see a patient at your OPD, to extend the same thought to them as well in terms of what all vaccines the patient should be vaccinated for that particular age group. and if they are vaccinated or not. I do understand that the practical challenges from the reminder to patients' acceptance, particularly in the field of preventive medicine, is very difficult. Treatment or acute care medicine is much easier for patients to accept as compared to preventative medicine. And that is where I think we have to put some extra effort to get that taken care of. So a triggering mechanism, a reminder system, and patient educational pamphlet and all those things, they has to be very, very important to have a holistic approach for our patients, because these vaccines, they will pay off in the long run. There is absolutely no doubts about it. If nobody has any thoughts to add, may I ask Praneeth to give his closing comments? Anybody has got anything to add on today's discussion before we close?
Excuse me.
Yes, sir.
At the end of this program, I would like to share my experience with one of my patients. Patient is a known atrial fibrillation with a heart failure. He was being given this pneumococcal vaccine, and immediately he developed ecchymosis, and there was a hematoma also. So what I suggest while giving the pneumococcal vaccine to any patient who is on anticoagulant therapy, please give with 23 number gauge needle or less than that if it is available. Then don't rub at the area of injection. Kindly press for 2 minutes at least, so that there won't be any hematoma. Otherwise, if you rub and if you leave it, a patient on anticoagulant, he may develop a hematoma. I have seen practically. This I want to share with the audience.
Sir, what you said is absolutely relevant. I think this rubbing business is very difficult. I think it's a old legend that that lot of our phlebotomists or nurses, they practice. Giving vaccination in the gluteal region serves one purpose, that you don't have to hold pressure. You can just give injection and sit, and that gives you a very good pressure there. But your point is absolutely well taken. Patients who are anticoagulated, where we typically say in therapeutic anticoagulation, we should not give IM injection, or if we give IM injection, we should be very careful. So these kind of vaccinations, which typically do go IM, we have to be careful about hematoma. So point well taken, absolutely, and it is very relevant in cardiac practice. Anybody else has got any other thoughts about this? If not, then Praneeth, if you could just give your closing comments for the session.
Yeah, so good session, Anup. There was a lot to learn. I should especially thank Shankar sir for his insight, and that introspection thing that has been said is really good. So I realized that I need to get a flu vaccine, and I could I remember that the hepatitis B vaccination. I don't remember when I took that, so that's again something which I need to check myself. But a lot of learning points about this vaccination, a lot talked about, but practical aspects are very much blurred. But a lot of practical aspects are being discussed, what are available, how to give, when to give, how to booster, and what to talk to the patients, and all those things. Yeah, it's all about, as I said, the commitment to do these things, put reminders. Only then we can be effective in preventing all those things. And as you said, these all are going to give a payoff in a on a long term. No immediate results, but we need to be consistent on all those things. I think the more we talk, the more we discuss, and the practice it kind of becomes as a habit. That's what we should aim for, I think. But definitely good topic to discussion, and had many points to learn. Thanks, Anup.
Perfect. Thank you, Praneeth. May I remind the audience that this is our last session for year 2020. We are going to take a break for rest of the December, given Christmas and New Year holidays coming up. Our next session will be on January 6th, and we will be back with a new topic at that time. I thank you all for attending today's session. Special thanks to Dr. Shankar for sparing his thoughts with us. To my attendees, please give us your feedback, how we can make it better. And if you found the session worthwhile, may we request you to share it amongst your colleagues as well. We host it every Wednesday. The next 2 Wednesday won't be there. January 6th will be the next one. The link that you used to join today's session will be the same link going forward in 2021 as well. So you can just use the same link. All our sessions are recorded, so you can search for the Weekly Huddle on the podcast or on the YouTube, and you should be able to get those recording. I run a bit behind in uploading those, so in case if you don't find the most up-to-date sessions uploaded, just email me and I should be able to do that. Having said that, I thank you all once again, and good night. We'll see you on January 6th, Wednesday, 7:30 p.m. Thank you. Good night, guys.